So just to remind you, I was talking about asking questions to improve recall and how you might do it before you start, while you're going through things, straight after this conference and later on. These are the questions I had for the tired patient. So when you're thinking about what would be a red flag, so we went through all that list. Are there any particularly that you think apply to your area of practice more than some of the other ones? Which one struck you as something you hadn't really thought of as a red flag, or what did you think of them? Just being aware and just asking yourself the question, what are the problems of over-investigation, being able to think about a few things to do with that. What diseases might creep up on you or on the patient or on the doctor and be commonly missed, but still be very important to pick up, and we mentioned a couple of those. And then what to do if you're still unsure of the cause. And that's talking about when you get down to someone who's couldn't really see anything, did some lifestyle intervention, and said wait for 4 weeks. What happens after that? Shall I give you HbA1c questions too, seeing we're going into HbA1c a bit next. So the question is trying to answer, what does the HbA1c show me? When you're thinking about patients, why are your patients having, or the practice patients having HbA1cs done? What might be the common things that upset forming HbA1c in the body, because we're measuring this thing that's formed during diabetes? What might interfere with how a laboratory could measure HbA1c? And then what the alternatives are if for some reason you can't use HbA1c in the... So which diabetic patients are you seeing that aren't really being tested with HbA1c? And maybe it's because they've got a funny haemoglobin. What test does your practice use? And there's a few different choices about what you can use that we'll cover off later on. So they're sort of the general things to think about. So talking about HbA1c and diabetes, first thing I'd like to talk about is the Pima Indians, and that's what they're renowned for, their nicely woven baskets. So they've got two other claims to fame. One is they live near a big teaching hospital, so they're near the big hospital in Massachusetts. And the other thing is they have a particularly high incidence of diabetes in their population for two reasons. One of them is largely genetic. So they're being close to a research institution and having a high rate of diabetes made them the prime candidates for really determining the whole world's approach to diabetes. And this is a look at the 2-hour glucose tolerance test. So this is a usual diagnostic test for diabetes, where you give someone a 75 gram sugar load and measure both their fasting glucose and then the glucose in 2 hours. And you'll see, this is the normal sort of spread of glucose as you expect from a healthy population. But in the Pima Indian, they have this big peak of people who have higher glucoses from 8 to 20 plus. If you did it in our population, you'd still see the same curve with the diabetics, but they'd be a much smaller little bump here, whereas this population has a very high peak because they've got a genetic predisposition as part of the reason they've got this high rate of diabetes. So why is that helpful? Well, if you're research people, you go off and research, and I'll zoom into this slide in a minute, but basically it's looking at different measures of glucose metabolism, glucose along the bottom, and this is a risk of developing complications, and in particular the whole point of treating diabetes, if you want to think of it in one way, is to stop the long-term very bad complications of diabetes. And so because this population had such a high rate of diabetes, it also meant they had a high rate of bad complications from diabetes, which made them a population where you could actually measure what was causing these complications more easily than in a population where you've only got a few diabetics in it. And what they did is retinopathy was used because, one, it's very bad, and two, it's easy to see. Peripheral vascular disease just as bad if you like, toes and foot problems, but a bit harder to get a handle on, whereas retinopathy, you can actually have a look at the retina fairly easily and grade it fairly easily, so it was a good research topic. And basically what they found is you go along, the people with the normal glucose is done too bad, but then suddenly you get this really jump up in the rate of retinopathy once you get above a certain glucose level. And if you zoom in on where it actually kicks up, these were basically accepted as a diagnostic criteria for diabetes. So for a 2-hour glucose tolerance test result, if you have a look here, they chose, and they actually chose in nice round figures in American units, but when you convert it to SI units, it's not quite as round. So 11.1 is the point here where the curve kicks up if you just have a look at the 2-hour glucose tolerance test results. If you look at fasting glucose, which is sort of lines up with the 2-hour result, 7 was the time when these complications seemed to kick up for the fasting glucose, and HbA1c was around 6.5% that things started kicking up. So this is really the Pima Indians, and the study that was done by the researchers was where we got these diagnostic criteria for diabetes based on trying to avoid these complications of diabetes. So this was done many, many years ago. The interesting thing is they weren't actually talking about HbA1c then, and the thing that's changed in the last couple of years in Australia, excuse me, and around the world is that we now can use HbA1c to diagnose some diabetes. So why weren't we using it all this time ago? It's because compared to glucose, HbA1c is really hard to measure. It's not too bad to measure consistently in one laboratory, but to directly compare one laboratory to another is a much more difficult problem. And one of the contributions the diabetes researchers made to the management of diabetes over the years is actually standardising HbA1c measurements so that now we've only just reached this time when it's comparable enough across the world to be able to use it as a diagnostic result. It's always been pretty easy to measure glucose, but much harder to measure HbA1c. And we'll talk about why measure it instead of glucose. The other thing I point out about HbA1c, and it's a funny name because it's really a chromatographic approach to finding out which bit of haemoglobin has some sugar stuck onto it because it's been in a sugary environment, is basically HbA1c. So it's a measure of sugar exposure of the haemoglobin to a sugary bloodstream. Usually it was presented as a fraction of hemoglobin A, of hemoglobin. One of the problems was this fraction just coincidentally seemed to be like a glucose level, sort of same ballpark, and so people would confuse the percentage fraction with glucose results. And so that's one of the reasons for suggesting, apart from it being a more SI type unit of nanomoles per mole, it's a figure that's different from glucose, and so people just don't confuse it as much with glucose, and that's as big a reason for using it as anything, for ease of interpretation. So just going back to the question of what is the HbA1c, we've got a pretty good idea of glucose in our circulation. And so this glycation is basically glucose floating around in our circulation. Our red blood cells in the circulation, inside the red blood cells, they're red because of the amount of hemoglobin that's in them. Hemoglobin's a protein, and because it's sitting around in the blood for so long, there's a consistent chemical rate of adding glucose to a particular amino acid in the protein. So it's got a particularly reactive little spot where glucose can stick on and change the hemoglobin. And luckily the rate at which that happens is sort of proportional to the amount of time that the hemoglobin's been in the circulation. And so if we take a blood sample, the thing to bear in mind is we collect the red cells from very early red cells when they're just fresh out of the marrow to old red cells, and the age span of red cells is about 120 days. So we sample a mixture of young and old red cells, take them to the laboratory, extract the hemoglobin, and look at how much of this HbA1c fraction there is in the circulation, and that reflects the glucose concentration over the last 120 days. So that's the essence of the HbA1c. And it's just important to understand that because we'll talk about all the places that can go wrong in linking up. Basically, HbA1c is proportional to the mean glucose concentration in the time. So the mean glucose concentration over the last 120 days will produce a certain amount of HbA1c, and there's quite a few guidelines in terms of management of diabetes in terms of HbA1c concentrations and glucose concentrations. So managing diabetes is why we're interested in the HbA1c from a laboratory point of view, and I'll say that's the relationship usually. So what can throw out that relationship between glucose levels and HbA1c? So that's how HbA1c should work, and we'll come back in a minute to talk about why that's not always the case. Again, I'm going back to position statements. You'll be sick of position statements, guidelines, recommendations by the time I'm finished. But this is a position statement. It was produced by the Australian Diabetes Society, actually headed by a Queenslander in this case. But what they were looking at is guidance of how to use HbA1c for the diagnosis of diabetes. And we'll zoom in on the recommendations. I'll zoom in on that more in a moment, but produce these set of recommendations. These are important ones in terms of HbA1c. The first thing is, don't do an HbA1c if you've got a symptom, someone who has symptoms you think are diabetic, go straight to blood glucose. So, although you can say, oh yes, you can diagnose diabetes with HbA1c, that's not the recommended approach if someone actually looks like they're diabetic or has symptoms of diabetes. Go to a diagnostic blood test. But if you've got an asymptomatic person, so there's nothing really to point out this person has diabetes at the moment, but they're at an at-risk group, and that there's a in their criteria of people who are at risk. Sometimes it's ethnic group. Can focus particularly on Aboriginal and Torres Strait Islanders. Sometimes it's about whether they've had gestational diabetes, family history. There's basically quite a long scoring system to work out what the risk of the person is for diabetes. I won't go into that scoring system today, but it's in the position statement. So if someone doesn't necessarily look like they've got diabetes, you score them on this, and if they reach a certain score, then they're a candidate for having an HbA1c as a diagnostic test instead of looking at blood glucoses. The other thing the guidelines say is you have to be aware of when this won't work, and so that's what we're really talking about today, the situations in which HbA1c is not reliable in terms of diagnosing diabetes, or even following diabetes for that matter. So again, we'll go through this step by step, but there's basically 5 different things that can confound the process. So first thing they talk about is increasing red cell production. So if you remember, the whole idea about HbA1c is it's measuring the effect of the glucose levels on a haemoglobin that's been sitting around for 120 days. But if something upsets the balance of the red cells in the system, so particularly here, if you've got a lot of fresh red cells coming out, then it skews your sample. If you want to think of it that way, you have a lot of young red cells that have only been there for maybe 20 days and less of the older ones. So in fact, it'll give you an artificially low HbA1c just because there's a lot of fresh haemoglobin that hasn't had a chance to react with glucose yet. So if you've got someone who's been anemic and you've treated them for the anemia, then you'll have a whole lot of fresh red cells. So if you give them, if they were B12 or folate deficient, you gave them B12 or folate, then they'll produce a whole new set of red cells because they think, Jesus, great, I can make hemoglobin again, and out comes the red cells. Similarly, if you give someone iron from iron deficient, who's been iron deficient, the body will figure out it can now make lots of fresh red cells, and will do that. Sometimes in patients with chronic liver disease, there are some conditions that will produce reticulocytes, which is a sign of very young red cells, and occasionally use erythropoietin therapy to sort of push the marrow to produce extracellular material. So they're situations where you're getting increased young red cells in the circulation. Next group of things is quite a large group of abnormal haemoglobins, and this is becoming quite common in some parts of our community. So, for example, in the South Brisbane community, where my laboratory at Princess Alexandra Hospital looks after that area. We have a lot of immigrants from African and less extent Asian, but also so a lot of immigrants come in from populations that have more abnormal haemoglobins than a typical, if you like, British population. So why is this the case? Well, actually, it's an advantage to have an abnormal haemoglobin in some situations. Usually, it's to protect you from malaria. So if you come from an area that has, over the centuries or longer, been a high malaria area, then one of the ways the body can actually bother the malaria parasites when they're in the blood is to have abnormal haemoglobins that will work against the malaria. So if you come, so there's some ethnic and like racial groups that have relatively high rates of abnormal haemoglobin because it's been an advantage to their racial group in the past, and there's been selective pressure to increase the abnormal haemoglobin. So although we call them abnormal, they're just sort of different from the standard haemoglobin and may be quite appropriate in some settings. But the problem with these haemoglobins is they may not react with glucose the same way as the standard hemoglobin A reacts. There's another type of hemoglobin, hemoglobin F, which is fetal hemoglobin, and what happens is when we go from being a fetus that has a different sort of need for hemoglobin, so they've got to handle oxygen differently from the mother and then through the placenta. When you come out into the big wide world and you're breathing for yourself, you change your hemoglobin over to hemoglobin A largely. But there are some people for genetic reasons have persistent hemoglobin F, and these are another people who have an abnormal hemoglobin profile. Another situation can be methemoglobin. So this is a hemoglobin that's been modified by a chemical reaction with the hemoglobin, and again it's a bit different. So these hemoglobins may react differently with glucose in the circulation. But I've also put a circle around our assay because, and if someone's interested I can show chromatograms to indicate why this is a problem in our assays, but there's two types of ways of measuring HbA1c. One is to separate out the hemoglobin by different charges. So basically you see a profile of peaks and troughs showing the different hemoglobins, and you can see where the different hemoglobins are, and you can say, oh, this is the one that's got the glucose stuck on, and we'll measure that. Another approach is to use antibodies or some other type of thing that'll latch onto glycated hemoglobins and measure them that way. But either way you're measuring it, you can have interference from these abnormal hemoglobins. So that's depending on your practice area, that may be a significant problem in managing some of your diabetics. Other type of things, these are sort of less important in some ways. You can reduce the rate at which the hemoglobin gets glucose put onto it. Sometimes it seems to be aspirin does it, sometimes high doses of vitamin C and E. And the increased intra-erythrocyte pH is just a fancy way of saying renal failure patients are a bit acidotic. So and renal failure is quite complicated in terms of HbA1c, because not only do they have this problem of the reaction going on in the red cell, but they also have different red blood cell dynamics as part of their anemia of chronic disease, for example. Then the other thing is, as well as the blood profile changing because of pushes from the other end with increased erythropoiesis, if you get increased erythrocyte destruction, that can also mean then you've got a younger group of red cells because the older ones are getting chewed through. It tends to be the older ones that break down more easily. And the other thing I'll do is if you're destroying red cells, often the body will respond by making more fresh ones. So it's another really way of driving the young red cells at the other end of the line, is because the older cells are being removed more quickly. There can be a number of drug reactions. Splenomegaly means if your spleen, which is what gobbles up a lot of the old red cells, if it's overactive, it can gobble up more red cells than it should be. Haemoglobinopathies can make some of the red cells unstable depending on the type of hemoglobin variant you've got, which will break down more easily. You've got some people which fall in the group of hemolytic anemias, so this is where someone's got an antibody or some problem with their red cell which make them break down more quickly, or it could be inborn error of metabolism inside the red cell that makes it more fragile. So these are all things that if you're destroying red cells, then you'll also shift the balance of red cells in your circulation. And then just focusing on assay problems again, I've mentioned the abnormal haemoglobins can affect the way the HbA1c is measured. There are some approaches that are fairly resistant to interference from abnormal haemoglobins, but sometimes you'll have an abnormal hemoglobin which will basically interfere with any system you like, or any system you might try. The other thing is there's a bit of laboratory practice here about how you might handle the testing of HbA1c in patients with abnormal haemoglobins, and what you should do is sort of work out what your local laboratory approach to it is, because it can vary from laboratory to laboratory. So for example, at Royal Brisbane Laboratory, we'll report the HbA1c even if there's an abnormal haemoglobin there, but we'll say this might not be right because there's an abnormal haemoglobin there, and then we'll do some other tests. Other laboratories will say there's an abnormal haemoglobin there, we can't report it at all, and so you'll find null results. So you just have to be aware of your laboratory's practice as to how they flag abnormal haemoglobins back to you. Yeah?
Go back to the erythrocyte destruction in rheumatoid arthritis. I think I missed, what's the mechanism there?
I think it's again the part of anemia of chronic disease. I'm not sure if the arthritis itself, the autoimmune process itself shortens the red cell lifetime. Pardon?
Does the autoimmune process destroy?
Don't know. I don't think so. I think it's more the like anemia of chronic disease, so the chronic inflammatory process. And the other thing they said is hypertriglyceridemia. So this is basically some patients, when you take their blood, it looks like milk, or red milk, pink milk. And so if someone's got really high triglyceride levels, again, it becomes very hard to actually separate out the hemoglobin properly to measure the percentage of, or the amount of HbA1c that's present there. Why this is particularly, why I mention triglycerides? Well, it's because it's in a diabetic population, and one of the primary hyperlipidemias of diabetes is a high triglyceride. So it's an interference that occurs more frequently in the very population you're trying to measure the HbA1c in. So it can be quite a problem with the group of diabetics that tend to have high triglycerides. So in summary, the HbA1c is reflecting the blood glucose over the last 120 days, but it assumes that you've got a normal proportion of the hemoglobin A, so it's A1c means it's the 1c fraction of hemoglobin A, so if you have other hemoglobins there, you're not actually measuring HbA1c. And it means you need to have a normal red cell lifespan. So if you've got blood loss that shortens the red cell lifespan, for example, renal failure, or those hemoglobin variants, plus the other things we mentioned, they can all interfere. So the next question is, well, what do you do if you've got a patient where the HbA1c might not be that good? One thing is, well, maybe you can fix the reason. So sometimes if it's due to some other condition and you can treat that condition, then once that condition's resolved or improved, then you can go back to using the HbA1c. So for example, you've had someone who's been anemic and you give them the B12 folate or the iron, and they have this flush of new red cells coming out. Once that's stabilised and they're just back to a normal sort of red cell turnover, then you can start using the HbA1c again, but you just can't use it during that period where there's some condition disturbing the balance between the red cells. The other approach, and it depends again on the laboratory, you may be able to use a different assay method. So some laboratory, and a lot of laboratories will have more than one way of measuring HbA1c. Usually there's an instrument that'll do high volume HbA1c measurements. So if you've got a couple of hundred HbA1cs being done every day, then you need to have an instrument that does things fairly quickly, and there's a range of those available. Some are very high-speed chromatographic methods, some are very high-speed immunoassay methods. But there will be often one main method for HbA1c testing in laboratory, but they may have other methods, either methods that are more applicable to different parts of their laboratory system. So Pathology Queensland has 34 laboratories through the state. There's 2 laboratories that measure the HbA1c with the high throughput chromatographic method, but there are other laboratories that use immunoassay type methods. So if someone comes to our central laboratory with a haemoglobin with a test that can't really be done on the usual method, sometimes we can send it to another laboratory, or you may send it to another laboratory system that has, like a private laboratory or another public laboratory that uses a different assay that may not have that interference. In practice, it becomes a bit hard to keep picking out particular patients for particular types of HbA1c assays. So although that can be done, it's not the easiest thing to do. Which means, well, is there some other way to work around it? And the 2 main ways, you'll see it called in the literature SBGM, which just means self-blood glucose measurements. And so basically, if you can't measure the cumulative effect of the blood glucose on the haemoglobin as the HbA1c, then just measure the glucoses. So these are the people that measure their glucoses before or after meals, or whatever their protocol is for measuring glucoses. And when they come along to the doctor, they've either got their list of glucoses to review, or they might have a glucose instrument that they use at home, which can then either send or download the glucoses to the practice to have a look at. So one alternative is to say, well, we can't use HbA1c, we'll just have to really focus in on the glucose testing. Obviously, that's a problem from the point of view of repeated sampling. You can also get now continuous monitoring glucose things, a little needle that sits under your skin and gets replaced every 3 to 5 days and can basically send glucose measurements regularly to your smartphone. Is another alternative to it. So that's something the patient does and is sorted out in the clinic. Another approach is testing other types of what we call glycated proteins. So if you think of it, what we're looking at is we found a protein, haemoglobin, that when it's exposed to sugary blood gets glucose added to it. Well, why doesn't that happen with other proteins? In fact, it does happen with other proteins, and either the plasma proteins as a whole, they tend to get bits of sugar stuck on them, or otherwise, particularly albumin can get sugar stuck onto it. And so the 2 approaches are measuring, most common is probably measuring what they call fructosamines. The reason they're called fructosamine is once the glucose sticks onto these proteins, it actually rearranges itself to be a fructose, which is only slightly different, so it's called fructosamine. And what this does, because the half-life of the plasma proteins is shorter than the half-life of red cells, then it's only really going back 1 to 3 weeks. So the last 20 days rather than the red cells that sort of measure the last 120 days. So it's a shorter term measurement of glucose, which can be an advantage or a disadvantage, but generally seen as sort of a disadvantage unless you're seeing the patient every 3 weeks. And the other thing is, I think it's just as you can have HbA1c changes because the red cells change their lifetime, or their time that they're in the circulation. The fructosamine also changes if the proteins change how long they're sitting in the circulation. And so if someone's unwell and they have what's called the acute phase response and your body churns out different proteins to sort of fend off an infection, there'll be all these fresh proteins coming into the circulation, and so that can upset the concept of the fructosamine reflecting the glucose concentration, because just like having fresh red cells will upset the HbA1c, having fresh proteins will affect the fructosamine measurement, so it's got its own problems. I think in some ways the biggest problem is really lack of guidelines, being a guidelines sort of guy, but I couldn't really find any good guidelines of managing by fructosamines. If you've got sort of local experience and people are happy, certainly I see our endocrinologists order quite a few fructosamines on their patients, so they've got their own individual ideas about how to manage the patients according to fructosamines, but there's not really the work that's been done in terms of HbA1c and studies that hasn't really been done on fructosamines. And if you have a look at the College of Pathologists online manual of pathology testing, which you can find by Googling, you'll see that they describe fructosamine testing as rare, so it's often not a way that people go. And I think in Australia anyway, glycated albumin is even a rarer test than fructosamines. You might see in other literature, particularly I think the UK seem reasonably keen on glycated albumin, so it will vary from place to place. So we'll just have a look at some HbA1c results, so just get an idea of what they look like. This is the laboratory I come from, or how we display it. So often you'll have a few things thrown together so you can sort of get an overall view. So we're telling you what the glucose was when we drew the blood. We're also giving the HbA1 result. We're giving it in two ways. The percentage way that stands for a particular glucose study that linked up HbA1c to management, so they do it as a percentage. The IFCC is the International Federation of Clinical Chemistry, who came up with the more SI unit ratio of moles per mole, nanomoles per mole, per millimole, so millimoles per mole is the same way as expressing it. And here, as I said, problem with this figure is that it looks like a glucose result, whereas this is obviously not a glucose result, and that's one of the advantages of having that unit. Because we're in a transition, we should try and eventually turn this off and just go purely on these figures in Australia, but that's probably a period of years before that happens. The other thing you can calculate is part of working out this relationship is that you can estimate an average glucose based on the HbA1c. Some laboratories report that, some don't. We choose to report it. And in terms of interpretation, you have these reference ranges which, well, you know your patient's not normal, so it's really in some ways not that helpful having just straight reference ranges. So what we also provide is some diabetic control target ranges. It's probably just derived largely from clinical consensus within our group of clinicians we look after. You may find different levels elsewhere. So what we're looking at is how low the HbA1c should be to reflect good diabetic control. You might not follow this in all patients. There are some patients that are more prone to hypoglycemias than others. So if you have a patient that has problems with recurrent hypoglycemias, you may actually run them a bit higher than other patients who don't have that problem. Just make the point that sorting out variant haemoglobins can be quite complex. This is an article that from me and mainly my two co-workers, where we had a patient that had this particularly severe hemoglobin E problem, and if you go into the article, we actually had to test a whole lot of assays to see which ones did or didn't work with the hemoglobin E. It's very hard just to know off the top of your head which particular hemoglobinopathy is going to work which way in these particular assays, and often the laboratory might have to go into some detail for particular patients to work out if they can use various tests or not. So in summary, that was talking about basically how the Pima Indians, because of their high diabetic complication rate, were able to give us that handle for finding out what are the cutoffs for diagnosing diabetes, and then if someone's symptomatic, you should be using blood glucose levels, but for the asymptomatic high-risk patients, we can use HbA1c testing. Bearing in mind all those complications, that although I went through all those complications, it might only be 5% of your diabetic clinic that has something like that going on, depending on your practice mix. Thank you. Have you got any questions on?
Yeah. My question is around the point of care and the
Yes.
laboratory test of HbA1c. Has there been any comparison to look at the difference? Because when I was working in remote, we used to use ECA to check HbA1c, but we never thought.
Yeah, no, they're really quite good these days. So the type of assay they use can be the same assay that's basically used in large laboratory testing. And a lot of work's gone into making sure those point of care ones can be used. The only problem in one sense is that when we're doing it in the laboratory and using a chromatograph, then we can actually see abnormal haemoglobins as funny peaks in the shape. I'll just do. So this is when I talk about chromatographs, what we do is we put the haemoglobin into a machine that measures where the different haemoglobins come out. And when we're doing that, we can actually see the abnormal haemoglobins and say, well, there's something going on here. The only problem with the point of care instruments is you just get an answer and you're not necessarily sure whether that's affected by an variant haemoglobin or not. Some places say that you should have your first HbA1c measurements done on one of these type of instruments that can see abnormal haemoglobins, and then if you're sure that person hasn't got an abnormal haemoglobin, then the DCA point of care testing's fine. Any other questions about? I think I flicked past it. One of the things I mentioned about the Pima Indians is not only did they have a genetic predisposition, but also the way they were treated probably shifted them from a traditional diet onto a very bad, sugary, floury diet because people cut the water off from their traditional areas. But that's just another reason why they're good for diabetes.